I would like to welcome everyone to my complex exam presentation. My name is Laura Bokor, and the title of my thesis is The Clinical Pathological Evaluation of Cutaneous Lupus. I'm a medical doctor and a PhD student at the Department of Dermatology at Semmelweis University. My supervisors are Bernadett Hidvégi and András Bánvölgyi. Within this program, I have been engaged in two projects, both focusing on cutaneous lupus erythematosus, but employing different methodological approaches. The first project that I was working on is the investigation of the efficacy and safety of novel therapeutical options in cutaneous lupus, and this was a systematic review and meta-analysis. First of all, I would like to provide some information regarding cutaneous lupus. Cutaneous lupus is an autoimmune skin disease. There are more than 300,000 new patients worldwide, and they are suffering from inflamed, scaling or scarring lesions, or they might have scarring alopecia. Due to these severe symptoms, these patients have a substantial decrease in their quality of life. Currently, the gold standard therapy for cutaneous lupus is either topical or systemic glucocorticoids and antimalarials. But unfortunately, glucocorticoids might have serious side effects, as you might have already known, and the response rate to antimalarials is only approximately 50%. Recently, novel therapeutic options have emerged, for example, biologics such as anifrolumab and small molecules like JAK inhibitors. However, only limited evidence is available on their use in cutaneous lupus. Therefore, our aim is to find the most effective and safest novel therapy for cutaneous lupus. According to our aim, our clinical question is, what is the safest and most effective novel treatment in cutaneous lupus? To answer this, we used the PICO framework, where our patients were patients suffering from cutaneous lupus. Our interventions were biologics and small molecules. Our comparators were placebo or no comparator at all, and our outcomes were efficacy and adverse events. We were measuring efficacy with the CLASI score, which is a specific score for the evaluation of cutaneous lupus activity and damage on a scale of 0 to 70. The number 50 means that the patient reached at least a 50% reduction in their disease activity after treatment. Here you can see the flowchart of my selection, where I started with over 18,000 records, and after several rounds of removals, I ended up with 58 eligible full texts. Our meta-analysis consists of two parts: a network meta-analysis for randomized controlled trials and a traditional meta-analysis of observational studies. In both parts, our outcomes were the number of patients who reached the CLASI 50 after treatment, the odds ratio of any adverse events, and the odds ratio of serious adverse events. Here you can see the plots from the network meta-analysis presenting the direct comparisons between treatments in terms of efficacy on the left and safety on the right. First, I would like to present you my results regarding the number of patients who had at least a 50% reduction in their CLASI activity score after treatment. On the net forest plot on the left-hand side, all novel therapies in cutaneous lupus are compared to placebo, and you can observe that there is a clear ranking between them. Based on our results, we can conclude that deucravacitinib was the most effective therapy of all, since more than 8 times as many patients achieved at least a 50% reduction in their disease activity when treated with deucravacitinib compared to those receiving a placebo. Moreover, both litifilimab and anifrolumab were also significantly more effective than placebo. On the upper right-hand side, you can see the p-score plot, where we show how confident we are in our rankings. On the league table below, I would like to highlight some indirect comparisons we made between these treatments. You can see that deucravacitinib and litifilimab were significantly more effective than baricitinib and ustekinumab, and anifrolumab was significantly more effective than ustekinumab. On this slide, I would like to present you the safety profile of these different novel therapies. On the net first plot, all treatments are compared to placebo again, and you can observe that there were no differences between the therapies and placebo regarding the odds ratio of any adverse events. In indirect comparisons, which are visible in the league table below, there were also no significant differences among the novel treatments in their safety profile. Therefore, we can conclude that these are safe treatments. Regarding the incidence of serious adverse events, no significant differences were found between the novel therapies and placebo, except for baricitinib. On this slide, I would like to highlight the strengths and limitations of my paper. According to our knowledge, this is the first comprehensive and comparative analysis of the novel therapeutical options in cutaneous lupus. Furthermore, the inclusion of a network meta-analysis component allows for a more robust comparison of these various therapies, which provides a more distinctive ranking of their efficacy and safety. Additionally, our analysis encompasses a large patient population, enhancing the statistical power of these findings. However, the study also has limitations, including the high heterogeneity of the quasi outcome measures across the included studies. And unfortunately, there are only few direct comparisons between the novel therapies, which limits the ability to draw definitive conclusions regarding their relative efficacy. In conclusion, deucravacitinib is the most effective and well-tolerated novel treatment in cutaneous lupus. Our implication for practice is the early use of deucravacitinib in the clinical practice, and also given its favorable efficacy and safety profile, deucravacitinib may warrant inclusion in future systemic lupus and cutaneous lupus guidelines. Our implication for research is that additional RCTs are necessary to address the therapeutical challenges of cutaneous lupus, specifically targeting patients with skin involvement alone and evaluating the efficacy of different novel therapies across the various subtypes of cutaneous lupus. And also a standardized efficacy measure is needed across the cutaneous lupus trials to enhance the comparability of the results and outcomes. Here you can see the current status of this project. The paper was published in December 2024 in the Journal of Autoimmunity Reviews. Now I would like to continue with my second project, which is the epidemiological evaluation of patients with cutaneous lupus, and this is a retrospective cohort study. The incidence of cutaneous lupus is 4 over 100,000. However, there are few available data on the epidemiology of the specific subgroups of this disease. Therefore, there are several open questions such as the difference in gender distribution, the prevalence of different autoimmune and malignant comorbidities, the differences in clinical and laboratory findings, the prevalence of systematization, or the epidemiology of the rare subtypes. Unfortunately, there is only one previous register, which was published in 2013, and it analyzed the data of 1,000 patients. Therefore, our aim is to collect data from the last 10 years at the Department of Dermatology at Semmelweis University, which is among the biggest centers for autoimmune skin diseases in Hungary. And we're aiming for the analysis of the prevalence of rare subtypes, the male-female ratio in different subtypes, different comorbidities, the prevalence of smoking or systematization, different circulating antibody profiles in the different subtypes, lupus band test positivity, and first, second, or third line treatment options. So in conclusion, our aim is to provide up-to-date epidemiological data of cutaneous lupus. So far, we collected data from 181 cutaneous lupus patients with their diagnosis confirmed by skin biopsy and histopathological examination. Here, I present the results of the preliminary epidemiological analysis. On the left-hand side, the clinical and demographic characteristics of these patients are displayed. The upper right panel illustrates the differences in their autoantibody profiles between the subacute cutaneous lupus and the discrete lupus subtypes. Below, two pie charts show the distribution of different malignant and autoimmune comorbidities within the cohort. These findings are just preliminary and the data collection is still ongoing. In summary, these are the two projects that I have in this program. The first one is focusing on the therapy of cutaneous lupus, and the second one is focusing on the epidemiology of this disease. Thank you for your kind attention.